Today I am going to talk about the microcytic anemia, about the general discussion, and also lead poisoning, how it called the microcytic anemia. So we already discussed about after find someone has we thinking that he has anemia, and next thing we did the measure the hemoglobin hematocrit value. It can normal, it can below the normal. We are thinking next thing we did the measure the reticulocyte and mean corpuscular volume. So mean corpuscular volume is below is less than 80%, 80 FL. And so we are thinking the mean corpuscular volume is below 80. We are thinking person could have iron deficiency anemia. This is the most common cause of microcytic anemia or anemia of chronic disease. This can cause, we have enough iron, but we have problem in utilization of the storage iron. So heme synthesis go down in all of this case except thalassemia. Sideroblast anemia decrease also heme synthesis. Thalassemia decrease production of globin. Lead decrease synthesis, decrease heme synthesis. So all of these cause decrease heme synthesis except thalassemia, which cause decrease the synthesis of the globin. Microcytic anemia, all of them has a problem in production of the red blood cell. So the reticulocyte, after the find the mean corpuscular volume is low, we found the reticulocyte, where reticulocyte also will be below the normal except thalassemia, which has 3 gene is deleted. So reticulocyte could be normal, but all of them will give microcytic hypochromic anemia, and all of them will have target cell. Is after we find out reticulocyte is low and mean corpuscular volume below 80, we need to come to the conclusion what is the diagnosis. So do we need to do peripheral blood smear? Is it very helpful to come to the diagnosis which one is causing among these 5? Actually no. More important is the history. If this guy has long history of the disease, so anemia of chronic disease, if he is a alcoholic, he can have sideroblast anemia, or is he have any genetics problem going on, like thalassemia. So after we know the person has low reticulocyte count, in corpuscular volume is below 80, what is the next step we can do? We have to measure the serum iron. Serum iron will give us some kind of hints what could be the diagnosis. So iron deficiency anemia, obvious. Serum iron will be low. And sideroblast anemia, serum iron will be high. Thalassemia has a normal iron level. Anemia of chronic disease, iron will be low, but if you measure the ferritin level, that will be high. But iron deficiency anemia, serum iron and ferritin both will be low. And so after we find someone has mid-corpuscular value below 80 and his reticulocyte is below the normal level, next thing we can do, we measure the serum ferritin level and iron level. This can cause us to narrow down our diagnosis. Let's talk about in diagnosis what are we going to use, what are we going to order. Like say we can use the peripheral blood smear to look for anisocytosis. What is this? It talk about the size of the red blood cell. So it could be variable size, like say someone has red blood cell in different size, 50 feet for example, 40 feet, 100 feet. So when this number is very variable, we are looking for what is the percentage of it in both cases. And when we see that there is a very unequal size and variable size of the cell, we call this anisocytosis. Red cell distribution width also mean the same thing. Folliculocytosis is talking about the shape of the cell. If the cell look like dick shape, if the cell look like football shape, if the shape look like soccer ball shape. So we are talking about this and we are looking at what is the percentage of it. And let's talk about the serum ferritin. When person has iron deficiency anemia, his serum ferritin also will be low. But person have iron deficiency anemia, same time he has going on some kind of inflammation, like the infectious disease is going on, and you measure his iron level and you measure his ferritin level. We are suspecting this guy has iron deficiency anemia, but his ferritin is high, and in this case we can do the bone biopsy. Usually someone have iron deficiency anemia, we found his serum iron is low, his ferritin is low. This is enough for us to tell that this person has iron deficiency anemia. We don't, but if we do the biopsy of the bone, there it will give us definite diagnosis. When we see after biopsy that his hemocytic is low, this gives us definite diagnosis that this person has iron deficiency anemia, but we don't need it. But when we are suspecting this guy has iron deficiency anemia and same time he has inflammation going on like infection and his ferritin is high, so in this case we can do biopsy of the bone to make sure that his hemocytic is low or high, because inflammation of the chronic disease, his ferritin is high, his hemocytic will be high. But person has iron deficiency anemia, sometimes he has infection going on and his ferritin is high, so we have to do the bone biopsy to make sure that he has iron deficiency anemia. When we will find he's after the biopsy that his hemocytic is low. So here we are talking about what we are going to order to make sure what disease this person has. One is red cell distribution with or anisocytosis, poikilocytosis, serum ferritin. Next thing, so when we found person has mean corpuscular volume below 80, we tell all of them has hypochromic microcytic anemia, and it can cause by iron deficiency anemia, anemia of chronic disease, sideroblast anemia, lead poisoning, beta thalassemia minor, and all of them has low reticulocyte count. Reticulocyte count also will be low if person has bone marrow fibrosis. And we talked it before, but we have to repeat this here again. If this person was in radiation therapy, if this person has infection going on in the bone marrow, or if this person has a cancer and it spread to the bone marrow, and this person could produce low amount of reticulocyte, or something caused that then this guy has bone marrow fibrosis. So folic acid deficiency also can cause low reticulocyte count. Vitamin B12 and lead poisoning we talked before. Also all of this cause a reticulocyte count will be low except thalassemia. What is about the transferrin? Transferrin is a protein, is in the serum. It carry iron at the serum. What is the total iron binding capacity? It's talking about the transferrin. How much iron is binded with the transferrin? So we talk it like this: total iron binding capacity. So when iron will be low, this guy has iron deficiency anemia, transferrin saturation will be low. Low amount of iron is binding with the transferrin. What about the capacity? Like say transferrin has capacity to carry 100 gram of iron. This guy have iron deficiency anemia, so his iron binding with transferrin say 20 gram, so his saturation is 20 gram, but his capacity is 100. So his saturation is low. Transferrin iron measurement of the iron, the transferrin saturation is low, but his binding capacity is high. And so make things clear again. Say transferrin has capacity to carry 100 gram of iron. In iron deficiency anemia it is 20. Let's say in a normal person it is 100, but he has 20. So his the saturation is low, but iron capacity is still, if you put more iron, he has more capacity to carry this iron because he have low iron. What is the erythrocyte sedimentation rate? When we going to order this? When we are suspecting that person has some kind of inflammation is going on. What inflammation do to the red blood cell? It make the red blood cell heavy. So you collect the blood from a person and you put in a test tube, and you see when we know, like say test tube is 1 feet long, we know for a normal person how long a red blood cell take from the up to bottom, come to the bottom, how long it take. Normal person, like say it take to 15 seconds to come from the up to the bottom. But when red blood cell become heavy in inflammation disease, it will take 10 seconds. So when we see this, we are thinking this person could have inflammation is going on. Now talk about, like say someone is taking non-steroidal, like say aspirin or this kind of thing he is taking, we are thinking he is losing blood through his GI tract. That is causing his iron deficiency anemia. And we already find out his hemoglobin hematocrit low, mean corpuscular volume below 80, reticulocyte is below normal, and his ferritin is low, his transferrin saturation, total iron binding capacity is high, transferrin saturation is low. So what we gonna do? We have to measure the serum iron. So again, we found person look pale and he has a history. You ask for, and he is taking, you saying he is taking NSAID, non-steroidal anti-inflammatory drugs, and you are thinking he's losing blood through his GI tract, this is causing his anemia, and you do the you did the hemoglobin hematocrit come low, and his microcorpuscular volume is below 80, reticulocyte is low, and then you do the measure the serum ferritin and total iron binding capacity, transferrin saturation all come low. Then you have to measure the serum iron to find out what is causing to find out if serum iron come below normal, and you are find out he has iron deficiency anemia. If someone eat iron, it absorb in his GI tract. what is going on, um, what thing is going on there. Iron will be in the system, and in the serum it will be bind with the transferrin. So we have iron, and we don't want to keep this iron in the system. So what transferrin do? Transferrin will go to a cell who has ferritin. This is a protein. So transferrin will transfer the iron to the ferritin. When it become ferritin bind with the iron, we call it ferritin. In the cell, it will be stored in the cell as a ferritin. When excess iron in the system, this ferritin will make the granule. Like say 10 ferritin will make one granule. Then this granule we call the hemosiderin. This hemosiderin we can easily see in the microscope. To a normal person, hemosiderin could be in the mononuclear phagocyte system. We can see this hemosiderin in the, let's say, in the spleen, in the liver, in the bone marrow has phagocyte cell, mononuclear phagocyte cell, and we see inside of the mononuclear phagocyte cell we have a hemosiderin. Someone has a scratch in their screen and he has hemosiderin on their phagocyte cell, take it, and we see the pigmentation on there. So when we talk about it go from the GI tract to the bone marrow, spleen, or the liver. When blood cell, the serum ferritin is high. When serum ferritin go low, the serum iron go low, what happened? Ferritin come out and it release the iron, then it take by the transferrin, and then we utilize this iron. But in anemia of chronic disease, this guy has a low iron. Ferritin come out to give iron, but it cannot separate the iron. So iron is low, but ferritin is high. So this is the cause happen in anemia of chronic disease. But in iron deficiency anemia, there is not enough ferritin in the bone marrow or spleen or in the liver. So not enough ferritin is coming out to give iron. So ferritin will be low, iron will be also low. So in transferrin is a protein which transport iron in the serum. When serum iron is low, transferrin is available to bind with more iron. We are talking about here why we are awarding for total iron binding capacity. So total iron binding capacity will increase. So what can cause, give little hints about what can cause the child have iron deficiency. If this child is only drinking mother milk or milk, would have low source of iron, he can have iron deficiency anemia. Pregnant woman can have iron deficiency anemia because demand of the iron increase in the fetus. And when iron will be the low, oxygen carrying capacity go down, our heart try to compensate, and by pumping the enough blood. So when heart try to keep up with the demand, with the need of the body, but after some time it cannot do anymore, then heart failure can happen. So we already discussed about the reticulocytes decrease in all kind of anemia, including bone marrow fibrosis, or bone is infiltrated with the infection or radiation or cancer cell. So in this case, after rule out all of these, when we didn't find that person doesn't have microcytic anemia, what I mentioned all of them, no macrocytic anemia, and no chronic disease, no trauma going on, no hemolysis going on, finally we have to make sure that person has problem in bone marrow, and we do the bone marrow biopsy. So two cases you have to look when you decide to do the bone marrow biopsy. When you are thinking, oh, rule out all of these, and then you come, then bone marrow biopsy, that this person have history of the infection going on, the radiation, he has a cancer cell infiltration, other is person has anemia, you thinking the iron deficiency caused it, but you found his ferritin is high. What is unusual case in iron deficiency anemia, but you found he has infection going on, some kind of inflammation going on, and that's why you found his ferritin is high. So in this case you do the biopsy and you found that his hemosiderin is low, and you found that he has iron deficiency anemia, but anemia of chronic disease, hemosiderin will be high, ferritin is high, hemosiderin is high. So these two cases you can do the bone biopsy. If red blood cell breakdown at the system, what happen is have iron, it bind with the haptoglobin that will carry the iron, and it will take to the liver, and haptoglobin will not let the iron to lose through the urine, and then this haptoglobin bind with the iron, that will be processed in the liver. We will talk about in other section. Now let's talk about the lead poisoning. Discuss a little bit about lead poisoning. Usually the professional people who are in the environment, like say old house, child is there, and or the construction worker working in a place where have lead around, they can have lead poisoning. And what lead poisoning can do, it can cause the problem, neurological problem in the kidney and in the GI tract, and we already know that it can cause the microcytic hypochromic anemia. So when it causes problem in GI tract, patient could have abdominal pain, constipation, and he has microcytic anemia, so it can cause him fatigue. And neurological problem, he can have peripheral neuropathy, he can have difficulty in concentration, insomnia. When peripheral neuropathy will develop, his extensor muscle will be weak, and that can give, if you do the physical exam, he will show some kind of clumsiness in his hand. And if you look at the what kind of problem it can cause to the kidney, renal disease. It can cause the interstitial nephritis. What interstitial nephritis you mean? When you do the biopsy, you see the tubule becomes swollen and inflamed. So lead can do neurological problem, kidney problem, and the GI problem. In the physical exam, you already found, you already know that he can have neurological problem. What will be the neurological problem? He could have insomnia, he can have concentration problem, and he could have peripheral neuropathy. We can call the muscle pain, and when his extensor muscle will be weak, that can cause the clumsiness, but his reflex will be the normal, will be intact. So in this case, we will measure to know that this guy really has lead poisoning. We'll measure the serum lead level, and also when with the peripheral blood smear, we will see basophilic stiffening. And if this guy kidney can cause interstitial nephritis, his creatinine could be higher. And how we will manage this guy? What treatment do you offer for him? We will tell him to avoid the environment where has the lead, and if his lead is really high, and we can give him EDTA Sasimer, but you will give when his lead is very high. But other case, if it be low, we'll tell him to avoid the place where he has a lead. So thank you. This is hematology part 2. This one I talk about the microcytic anemia, general thing, and lead poisoning. In part 3 we will talk about the iron deficiency anemia.